Hello. Good afternoon. My name is Jared Feyko. I'm a vascular surgeon with Cardiothoracic and Vascular Surgical Associates. Today, I am giving a talk to highlight a couple very important and very common conditions that a vascular surgeon sees in practice. Um, I am part of a group that's been in town, which has combined um, a number of vascular surgeons as well as a number of cardiothoracic surgeons in this group. And in particular, my practice is based at Baptist Beaches as well as at Baptist Downtown. So, for potential patients who live in these parts of town, there's now vascular surgery services out towards the beach. So, first, one of the things I wanted to highlight is what is vascular surgery, and why is this relevant to patients? A vascular surgeon is a surgeon for arteries and veins throughout the body. And so this is a very comprehensive specialty that essentially includes any arteries outside of the arteries for the heart or arteries inside the brain. And we treat all of these arteries surgically, including both open surgical techniques where we would be making an incision, as well as very frequently these days, minimally invasive techniques where we can essentially do interventions through a large IV in an artery or a vein. Historically, vascular surgery, the operations on these types of arteries were frequently done with a piecemeal type of approach, where some surgeons would do the traditional open surgeries, and cardiologists or interventional radiologists would take on a lot of the what we call minimally invasive or endovascular types of procedures. Modern vascular surgery, contemporary vascular surgery, is done by a vascular surgeon who's capable of performing the entire breadth of these interventions for patients. We're capable of managing them from a medical perspective, interpreting their ultrasound testing, performing all of the minimally invasive procedures, the full spectrum, as well as all of the traditional open surgical procedures. So when available in a particular region, a vascular surgeon can provide, and is the only specialty that can provide, comprehensive care to patients who have disease of their arteries or veins. I'd also like to just mention for any listeners who are listening live, this will also be posted to the First Coast YMCA site for on-demand view. If there's any questions while the talk is going on, please type in and ask your questions, and we'll try to make this as interactive as possible. So the first big topic that I want to address, and there's going to be two big topics that I'd like to bring up, and this is not the full spectrum of what my specialty treats, but these are the two most common conditions, and they're often overlapping, and there can be some lack of clarity from primary care doctors who may not understand which is which. So I want to cover both of these two topics and help potential patients understand these so they can have an informed conversation with their primary care doctor. So the first topic I'd like to talk about is called peripheral arterial disease or peripheral vascular disease. So what this is when a patient develops narrowing or blockage of the arteries in the legs, or the arteries that go into the legs in the pelvis. Now, this process is the vast majority of the time a pathophysiologic process known as atherosclerosis. And this is colloquially referred to as hardening of the arteries. And this is a systemic process. This doesn't exclusively happen to arteries that go into the legs. it happens all over one's body as typically a patient gets older and in conjunction with a number of well-described risk factors. So it's well understood that patients who have poorly controlled hypertension, poorly controlled diabetes, patients who smoke or use any sort of tobacco products, patients who have a family history, they're more prone to having these types of narrowings or blockages develop in the arteries all over the body, including the arteries that go to the legs. Um, in terms of prevention and medical management, this is an important part of taking care of these patients. And essentially, these would be interventions or medications that one's primary care doctor would prescribe. And so the medical management for this type of condition would focus on controlling these risk factors. So controlling uh, blood sugar if a patient is diabetic, controlling blood pressure if a patient has high blood pressure, controlling cholesterol if a patient has high cholesterol, encouraging smoking cessation if a patient smokes. So these types of risk factors would really be managed by a patient's primary care doctor, and that would be the focus on preventing this condition in the first place. Now, if a patient develops these types of narrowings in the artery or blockages in the arteries in the legs, um, these types of risk factor modification therapies would not resolve the blockages and make them go away per se, but they will help stabilize them. They will help control their symptoms. And moreover, these would have a number of other benefits systemically for the patient to control these types of risk factors anyway, so these should certainly be done by a patient's primary care. Um, the symptoms that a patient would experience, and this is really probably one of the most important take-home points from this talk, so that patients can identify these symptoms and bring them to their primary care doctor's attention. The symptoms that a patient would experience for peripheral arterial disease fall into two broad categories. The first, which is the more minor of the two, is called claudication, and that is simply the medical term for when a patient has pain in their legs with walking because of poor circulation to the legs and feet. So if a patient has more mild degrees of narrowing or blockage in the arteries, when they walk a certain distance, they will experience pain, but only experience pain with activity. The classic type of symptom associated with claudication is where a patient walks a certain distance, and at that exact distance, they experience pain, which can be cramping, can be early fatigue in the legs that requires them to stop walking. And when they stop walking, within a few minutes, that pain goes away completely. And then when they walk again, that exact same distance, the pain recurs at the exact same distance. And that is what we would call classic symptoms for claudication. That is very, very characteristic of patients having blockages or narrowing in the arteries of the legs that are causing those symptoms. Now, patients will not always have that exact type of classic presentation, and so the presentation can become more muddied, and it may not be entirely clear to the patient or their primary care doctor what is causing their pain. So patients may only experience pain with walking upstairs. They may only have early fatigue. They may have heaviness in the legs that is not a clear cramping type of pain. They may have a restless leg type of phenomenon. And so the presentation can extend to some of these more non-classic symptoms, like I mentioned. So that is the first broad category of what we call peripheral arterial disease, is claudication. Now, the treatment for patients who have claudication is largely non-surgical. If they are able to walk a sufficient distance where they don't feel like their symptoms are limiting their lifestyle, then they should be managed medically and non-surgically. And by medical management, again, that means risk factor modification. So patients should have their blood pressure well controlled, their cholesterol well controlled, their blood sugars. They should quit smoking, and they should be taking at least an aspirin or some sort of what we call an antiplatelet medication on a daily basis. When the symptoms become severe enough, that is when intervention is warranted. And there are a couple classes of medications which can additionally help patients improve walking distance through vasodilator type of mechanisms, which can help them avoid surgery for longer. And moreover, these patients, even though they have pain when they walk a certain distance, they should continue walking, and they should walk as much as possible up until they get that pain, and then continue once they have to rest. So at this point, looks like there's just a question about claudication in the upper extremity. Can claudication also happen in the arms, or is something that only happens in the legs? It can happen in the upper extremities. It is far less common to happen in the upper extremities because, number one, our upper extremities don't require as much blood flow when we're active because we don't walk on our hands, we walk on our legs. And the collateral circulation in the upper extremities is very robust. So even patients who have complete blockage of the arteries in the shoulder area, the subclavian arteries, many times they will have no symptoms whatsoever. Now, if a patient does have symptoms from arterial blockage in the upper extremities, the treatment in terms of medical therapy and the indications for surgical therapy are very similar. And again, very frequently, these blockages in the upper extremity can also be managed with minimally invasive techniques. So I'd like to move on to the other broad category of what we call peripheral arterial disease, which is called critical limb ischemia. And this is made up of two types of presentations, which both represent a far more advanced form of peripheral arterial disease. So these two types of presentations are, number one, rest pain, where patients have pain in the feet when they're not active. So they are just sitting or just standing, and they have pain because of severely diminished circulation in the legs. The other presentation in this category would be gangrene. So this can be somewhat subtle, or it can be more advanced. A patient may simply have a very small ulcer on the toe that is just not healing at an expected rate. A small ulceration, if everything else is within normal limits for that patient, should really heal within a matter of days. But if it's taking weeks and months and it's simply not getting better, there may be an underlying circulation issue which should be evaluated. Now, this type of presentation for patients for critical limb ischemia, this represents, as I mentioned, a far more severe form of this disease. They have more extensive blockages, and this represents overall a significant risk for limb loss. So there is an urgency to treating this, and all patients who have one of these two forms of peripheral arterial disease, ischemic rest pain, where they have pain without activity, or gangrene or non-healing wounds on the feet without surgical intervention and improving the blood flow to the legs, these patients have an approximately 25% risk of a major amputation in a 1-year time period. So all of these patients require urgent vascular surgical evaluation and ultimately procedures to improve the blood flow. Whereas patients in the first category that I mentioned with claudication, that is not a limb-threatening condition. If those patients have pain with only walking, they will continue to have that discomfort with walking, but if it is not corrected surgically, meaning if it's not corrected in a way to improve the blood flow, those patients will not have a significant risk of limb loss. They have an extremely low risk of limb loss, which is why a more conservative non-operative approach is generally taken with those patients. So this brings me to, again, talking about some of the treatments, and I'd like to get a little bit more detailed into this. And as I mentioned in the beginning of the talk, when I was introducing myself and my specialty, I mentioned that as a vascular surgeon, we provide comprehensive vascular care to patients with arterial pathology, venous pathology, and whether they require minimally invasive techniques to treat their condition or traditional open surgical techniques. So when a patient needs referral, we're able to provide them with any type of therapy that is available based on what is best for the patient, whereas other specialists are limited to only open surgical techniques or minimally invasive techniques. So let me just back up for a second. And let's, from a patient perspective, if you are experiencing pain with walking or some of these more gray area type of symptoms, heaviness or leg cramps or restless legs, this is something that you want to bring to the attention of your primary care doctor. And when you bring this to your attention of your primary care doctor, there needs to be some testing that's done so that these conditions can be confirmed, particularly if it's a non-classical type of presentation. These tests are very simple to do. They're non-invasive. So we need arterial non-invasive testing, which essentially is an ultrasound in conjunction with putting some blood pressure cuffs on the legs. It measures the pressure of the arteries in the legs and gives us some additional anatomic detail for the arteries. So confirm if there are in fact narrowing or blockages of arteries in the legs. And this testing is really the crux of what allows us to confirm the diagnosis. So if you suspect, you have some of these types of symptoms, I would encourage everybody to very carefully, bring this to the attention of their primary care doctor, get the testing, and then they should seek vascular surgery consultation after that. So to get back to some of the specific treatments that are available, most of the time, a patient who has claudication that's become disabling or has rest pain or gangrene, their condition can be treated with minimally invasive techniques. So the devices and technology that is now available is it's very advanced. There are a lot of options available and a lot of approaches available. So when someone has an indication for improving the blood flow in the legs, typically what we do is bring them in for an outpatient procedure. So these procedures can be done within an hour or two as an outpatient in an outpatient surgery center or at the hospital. And what we do is give the patient anesthesia and then put a IV in the artery, which gives us access to the artery. Most frequently, this is done in the femoral artery in the groin. This doesn't involve making an incision. It involves making essentially a large puncture, like a large IV site, which is maybe half a centimeter in size. This gives us access to the artery. And then from there, we can use various different techniques. So the most common technique is called an angioplasty. And that simply means where we use a balloon to go across a narrowing or a blockage, and we open up that blockage by inflating the balloon. Frequently, these days, we use drug-coated balloons. And this is a type of technology that's been available for coronary intervention for a longer time and has now been shown to be beneficial in the arteries and the legs. So we will use balloons that are impregnated with anti-proliferative medications, which help keep these narrowings and blockages open longer once they've been treated with the balloon. Other types of techniques that we will frequently use is something called an atherectomy. And what that means is you're using some sort of a device to remove some of the plaque from the inside of the artery. So there's a number of different devices that are available. Some are directional, some are orbital, some spin and decrease the plaque into very microparticles. Some actually remove some of the plaque and you take it out. But what is a very common approach for the arteries in the legs is to use these devices to remove some of the plaque and then treat the narrowing with a balloon that's impregnated with an anti-proliferative medicine. And this works very well, and it doesn't leave any sort of foreign body behind in the artery. This gives a full array of treatment options in the future for retreating these blockages if they recur. The other minimally invasive techniques that we have available include putting stents in, and there are various different types of stents. Some have the same type of anti-proliferative medication, just like the balloons that I mentioned. And they are sometimes necessary. They're not routinely necessary, but when they are to help keep a narrowing or blockage open after it's treated, we will use those as well. So there's a number of these devices available, and there's a number of treatment approaches in terms of access. So as I mentioned, the most common way to do this is through the artery in the groin. This is very well tolerated. But in certain circumstances, based on a patient's anatomy, other approaches may be necessary, and these can also all be done by a vascular surgeon. So sometimes we will use the arteries in the upper extremity, either at the wrist or at the elbow, and we will put the IV in the artery there, and then go down to the arteries in the leg from that approach and use the same types of devices that I mentioned, balloons or atherectomy devices or stents. And then lastly, we can also approach these arteries from the arteries at the ankle or foot. And again, for certain anatomic situations, sometimes this is the best option or the only option for treating these patients. And we will obtain access there, again, by putting the IV in, and then treat the artery with the same type of technologies that I just mentioned with balloons or stents or atherectomy devices. So most patients who are going to have disabling claudication where they need a procedure done to improve the blood flow, or who have gangrene or rest pain who need something done to save the limb to improve their blood flow, most of the time this is being done with minimally invasive techniques. And even though this is being done by a surgeon, vascular surgery really involves a lot of minimally invasive techniques in contemporary practice. Now, in addition to these minimally invasive techniques, there are still situations where it's necessary to do a traditional open surgical procedure, which vascular surgeons also do routinely. There are certain locations of blockages or narrowings in the artery where the best first-line treatment for improving the blood flow is a traditional open surgery. And the reason for this is because the outcomes are superior to doing these other types of minimally invasive procedures. So we decide what is best for the patient, regardless of whether it's an open or minimally invasive procedure. And that is kind of getting back to my point about why vascular surgery provides comprehensive care for these patients. So in kind of elaborating on that, there are still reasons to do traditional open procedures. So sometimes we'll make an incision over an artery, open that artery, and remove the plaque with a standard open technique that's called an endarterectomy. We do that very frequently in the common femoral artery in the groin. There are also sometimes it's not technically feasible to open up long blockages with balloons or stents or atherectomy devices, and sometimes we still have to do a bypass. And a bypass is a operation where you're taking a conduit around the blockage by sewing it above and below the blockage of the artery in the leg. And this is a procedure where the patients will have to be admitted to the hospital overnight, and there's more postoperative pain associated with this, but when it's done appropriately, still has excellent outcomes for the patient. Lastly, patients who have blockages in the arteries always require surveillance. This is a chronic condition is how I always have this discussion with my patients, where you have to think about it more along the lines of having diabetes more so than akin to having appendicitis. If you have appendicitis, you get one operation and your appendix is out and it's not going to come back, and you don't need to keep following with your surgeon after you have your appendectomy. But when you have diabetes, this is a chronic condition. You take insulin to manage it. It doesn't go away just because you take insulin. It's something that you have to remain vigilant with and continue to manage, because it's going to be something that's with you for the rest of your life. But if it's managed well, then the outcomes, again, can be excellent. So what we do is we medically manage these patients until there's an indication for a procedure to bring more blood flow. When there's a reason to bring more blood flow, we decide on the best procedure. We do that, and then after the patient has had the operation to improve the blood flow, we have to follow them serially for the rest of their life, because we know in this specialty that whether it's an open intervention or a minimally invasive intervention, so whether it's a stent or a bypass, none of these interventions have a lifespan of 100%. They're never going to last forever. At some point, these interventions will become blocked off again, and we may have to do a secondary procedure in the future. So the outcomes will be better for these patients if they are followed appropriately after their procedures. And we follow these patients again with the same kind of testing that I described before, where we do ultrasound testing and use blood pressure cuffs on the legs to check these bypasses or stents, whatever the case may be, and identify problems early when the reintervention options are simpler and the outcomes will be better. So, for example, if you're a patient who's moved from another area, or you've had some sort of procedure done on your arteries in the past by a doctor who you don't see any longer, these are implants and procedures that you need to have somebody following, even if you feel well, even if you do not have any current symptoms. You should have regular surveillance, which usually simply consists of coming into the office once a year for ultrasound testing, and vascular surgeons are trained to interpret these studies, so we know very well what we're looking at. There's another question here from someone who's viewing that is mentioning that she has symptoms of restless legs and arms. So I would encourage anybody with this type of symptom to first see your primary care doctor and mention what you've heard in this talk about the potential for this to be a symptom of arterial disease, and they can start by getting some of this simple non-invasive testing, and then if this confirms arterial disease, then you should be referred for vascular surgery consultation. So at this point, that concludes what I wanted to talk about with peripheral arterial disease, and I wanted to move on to the other broad topic that we see in our specialty, which is chronic venous disease. So of course, arteries and veins are different. Arteries bring blood flow from our heart down to our feet. Veins return blood flow from our feet back to our heart. And we treat both conditions. They have different types of symptoms, but they're frequently confused by even certain physicians who this isn't their area of specialty. So there are a spectrum of issues that patients can have with their veins and their leg. So this is what we call chronic venous insufficiency. And what this means is that the veins are not functioning properly. And this can provide, as I mentioned, a spectrum of different symptoms. So the veins in our legs are very different than the arteries. They are low pressure, they're high capacitance, they function differently. The way they function is to bring blood away from the feet back to the heart. And the way that they do that is they have a series of one-way valves in them so that the blood can be pumped against gravity, and it works similar to the way a lock system would work in a canal. So our muscles contract when we walk, it pumps the blood up one level, the one-way valves stop it from going back down towards your feet, and so on, and the blood eventually gets pumped out of your legs back to the heart so it can be recirculated. Well, these valves can become incompetent, they won't work for various reasons, and it's very common to have this. It can be as simple as um, patients who have jobs where they stand for very long periods of time for many, many years in a row, and they will develop chronic venous disorder in their legs as a result of that. If patients have ever had a blood clot in their leg, sometimes these things are congenital in nature, and that's why patients can develop symptoms like this. So what you'll see is a spectrum. So if you're having incompetent veins, we call that venous insufficiency. It doesn't mean that you have a blockage in the vein. It means that the valves aren't functioning properly and the blood is going down towards the feet for a longer period of time than it should. That causes an increased pressure in the veins in the leg and a number of potential symptoms. So that spectrum of symptoms is, we grade it 1 through 6. It goes from having small spider veins, which are less than 3 millimeters in the legs or feet, to varicose veins, which patients are usually much more familiar with, which are larger veins in their legs, usually on the inside of the calf or the thigh that you can feel with your fingers, to chronic leg swelling, to skin changes, where typically, most commonly, you'll see hyperpigmentation on the inside of the calf, or the most severe manifestations of this chronic venous disease is where patients will actually develop ulceration, breakdown of the skin, again, most frequently on the inside of the calf. Patients who develop any of these spectrum of diseases, again, should be worked up and sent to a vascular surgeon, where we can, again, provide comprehensive care, whether they need a minimally invasive procedure or an open procedure. The workup is, again, an ultrasound. And this should, again, be brought to the attention of one's primary care doctor, and the appropriate test, the ultrasound, should be ordered and then referred to a vascular surgeon. This is sometimes a point where primary care doctors don't realize that this is a different type of test than simply a test for a blood clot in the leg. This is called a venous insufficiency ultrasound, and that is the best test that we can evaluate these veins in the legs to see if they're functioning properly and if there's something that surgically we need to do about them. So that is the appropriate workup, and once that is done, one should be referred to, again, a vascular surgeon. So I talked about the presentation. We'll talk about the management of these venous disorders. Now, the fundamental management is to wear compression stockings. These are not simply sweat socks that are tighter than normal. These are actually medically graded compression stockings, and they come in various different degrees of compression, and they come in different heights. So some are thigh high, some are knee high. And this should really be spelled out by the specialist in terms of what types of stockings you need based on the symptoms that you have. The more advanced symptoms need higher degrees of compression, and the more mild types of symptoms need lower degrees of compression. And depending on what part of the leg it's affecting, they should either be worn all the way up to the groin, all the way up to the upper thigh, or sometimes you only need to have them knee high. So that is the medical therapy. And you really want to wear these compression stockings as much as possible. They work tremendously well. They will help patients' symptoms resolve. They will help ulcers heal. They will help symptoms from varicose veins abate. But if they're only worn a couple hours a day, they really don't do you a lot of good. They need to be worn as much as possible, unless essentially you're sleeping or in the shower or exercising. They should really be worn to have these types of effects. So with the spider veins, which are these very small veins, these are just really a cosmetic issue. And if it's something that is concerning for a patient from cosmesis, there are simple procedures to address them. It's called sclerotherapy, and they can be injected with a very small dose of a sclerosant, which causes these veins to shrink, and then the appearance of them will go away. This is generally a cosmetic procedure. It's not something that causes symptoms of pain or swelling in the legs. The next category of disorder in terms of severity is a varicose vein. And varicose veins um, can cause a number of different symptoms. They can cause pain, they can cause itching, they can sometimes bleed. Frequently, women will say, while they're shaving their legs, they nick one of the veins with the razor and it causes it to bleed, and that can be an indication to address them. And varicose vein procedures are frequently reimbursed by insurance, whereas the spider vein treatments is, as I mentioned, more of a cosmetic procedure. It's not reimbursed by insurance. And so, again, going up with leg swelling and then ulceration, these are also indications for procedures in the appropriate setting. So, not everyone who has a varicose vein or has some sort of vein disorder will necessarily be a candidate for a surgical procedure. It depends on a number of factors. And it depends on the outcome of the testing that I mentioned, where you get that very specific type of ultrasound test on the legs to determine which veins are not functioning properly in the leg. And based on that, we know if it'll actually help a patient. So the veins in the legs, there are several systems. There are deep systems, superficial systems, and connecting systems. And when the deep system is involved, there's very little that can be done surgically for that. Those need to be treated with compression stockings. When the superficial system is affected, that can be treated with a very simple procedure. And that procedure is minimally invasive. It involves putting an IV in that vein, and this can be done in the office setting. It doesn't need to be done in the hospital. And we use a device with a heating element to it that closes that vein down by using the heat. It essentially scars the vein and closes it. And in doing so, you're closing down that incompetent, insufficient segment, which will cause varicose veins to abate or help wounds on the legs from veins to heal faster and decrease the recurrence rate. So if, again, patients have these types of vein symptoms, they should have this kind of workup done by their primary care and be referred to a vascular surgeon who can review this with you and discuss your candidacy for an elective vein procedure. Most commonly, as I mentioned, it involves closing down that superficial vein. This can be done in the office. Our group is affiliated with Ellison Vein Institute, and we do all of these types of vein interventions in an office setting. So it's a quick turnover. It doesn't involve going to the hospital or having general anesthesia. There are secondary procedures that could be done to directly address the varicose veins, where we can directly treat those with sclerosant agent to close them off, or do a very minor surgical procedure where we start another IV essentially in that vein and then close it off directly. And these, like I said, can all be done in the office setting. There is a fair bit of overlap between patients who have peripheral arterial disease and have venous disease. They can have both. If you have a patient who has blockages in the arteries and you need to wear compression stockings, those patients should be referred for vascular surgery consultation to see if it's safe to put them in compression stockings, because very, tight degrees of compression can be a problem with someone who already has decreased circulation. So these conditions can coexist, and they frequently do. And again, they should be referred for a consultation. The last quick topic I wanted to address, and I'll just kind of briefly go into it, is DVT. So this is a deep venous thrombosis. This is different than the venous insufficiency that I mentioned. It's a different pathologic process. It's an extremely common diagnosis. It is simply a blood clot in the vein in the leg. It happens frequently to patients around the time of surgery, around pregnancy, around periods of prolonged immobility, a long plane flight. And for many, many years, the standard treatment for this was simply medical. It was to simply take a blood thinner and wear compression stockings. There has been recent data, high quality level 1 trials that were done that looked at interventional options for decreasing long-term symptoms for patients who have DVTs. And there are now minimally invasive options available to treat these patients, where these studies have shown long-term benefit in certain patients. Um, Not all DVTs, and really a small minority of them, um, would benefit from intervention, but certainly there are a proportion of them that do benefit from intervention. And it's usually in younger patients or middle-aged patients who have blood clots in the veins in their legs that are higher up in the groin or in the pelvis. And as I mentioned, there's a variety of different techniques available to us now to remove these blood clots, to open these veins up with balloons or stents. And the more recent studies, as I mentioned, show that these patients have long-term benefits in terms of long-term symptoms. So just as a patient who has venous insufficiency can have chronic leg swelling, can have chronic wounds on the leg, can have chronic varicose veins, these types of symptoms are lessened in select populations if you have a procedure to have that clot in the vein removed. And so those patients should again have that discussion with their primary care doctor and be referred to a vascular surgeon for consultation. Most of these patients probably will not be candidates for a procedure, but the ones that will certainly see benefit if they have that type of procedure done to remove the clot. And so those are the two broad topics that I wanted to mention. And I think just to briefly summarize some take-home points from this kind of talk for patients, as this discussion is directed directly to patients, not to physicians, is I think the biggest point I can make is if you have the types of symptoms that I mentioned related to poor circulation in your legs, whether you have pain with walking, non-classic symptoms, heaviness, restless legs, this is something that you should bring to the attention of your primary care doctor, ask them to order the testing that I mentioned, and you want to be evaluated by a vascular surgeon who can provide comprehensive care, and whether it's non-operative management, medical management, minimally invasive procedures that are needed, or traditional procedures needed, you'll get the appropriate direction from that consultation. And then lastly, with venous disorders, these are extremely prevalent, far more common than arterial pathology. The venous disorders, varicose veins, venous wounds, as I mentioned, these need to be worked up with the appropriate testing. And the most common mistake you'll see your doctor make is they'll order a test for what's called the DVT ultrasound and not the insufficiency ultrasound. If they get the insufficiency ultrasound, those patients should always be referred to a vascular surgeon to be evaluated for candidacy for a procedure that can help them. And not all of them necessarily will need something done, but they can have that consultation. And this happens in conjunction with arterial disease, and we can provide a comprehensive discussion with the patient when they come and see us. So again, my name is Jared Feyko. I'm a vascular surgeon with Cardiothoracic and Vascular Surgical Associates in Jacksonville, Florida. And I personally practice at Baptist Medical Center in Baptist Beaches. And thank you all very much for your attention for this video. There will be contact information for our group for patients and referring doctors in the notes for this talk. Thank you all very much.